Hello, my name's Dr. Alia Munir. I'm a consultant endocrinologist in Sheffield, and I'm delighted to be here at this educational webinar. So I'd like to thank Kathy and the team from Neuroendocrine Cancer UK for inviting me. And the topic for today is diabetes mellitus, or sugar diabetes and neuroendocrine cancer. I don't have any disclosures for this talk. So over the next 20 minutes or so, I'd like to go through what diabetes mellitus is, and this audience will be familiar with neuroendocrine cancers. And I'll touch on the existing guidelines that we use for management of diabetes, and then I've picked out some recent trials that I thought may provoke some interest. I'll also like to share some unpublished data from an audit that we've done in Sheffield, and then perhaps make some suggestions for future directions. So for the purposes of this talk, I'll mainly refer to the well-differentiated neuroendocrine neoplasms as NETs, and I'll very briefly touch on neuroendocrine carcinomas if needed in the talk. So as we know, neuroendocrine tumours are relatively rare, but we know that their incidence is going up. And they can arise from many sites, and particularly from the small bowel, pancreas and lung. And some of these tumours can secrete hormones. These hormones can be diabetogenic and be associated with syndromes such as the multiple endocrine neoplasia syndrome. We know that individuals with cancer per se are at increased risk of developing diabetes mellitus. And this sometimes can be due to the site of the tumour involved or the treatments given. But what data do we have that this may hold true in NETs, and does it in fact have any impact on survival or treatment? So currently, when we're managing patients with cancer generally, we have two guidelines that we can refer to. The guideline from the Joint British Diabetes Societies in the peach basically gives us guidance on how to manage blood sugars for patients that have cancer in hospital. And then there's also a position statement for those patients that live, that are not in hospital and that are outpatients living with diabetes mellitus. And the aims of these statements are to reduce the risk of glucose-related emergencies in patients that have cancer, but they're not specific to neuroendocrine tumours. And we know that up to 1 in 5 patients with cancer may have diabetes, so this is not insignificant. So just because I love words, diabetes mellitus comes from the Greek word diabetes, which means siphon, and the Latin word mellitus, which means sweet. And patients have a high blood sugar, and the urine can be sweet, and we'll be familiar with the classification of diabetes as type 1 and type 2, but there are other classifications that actually even healthcare professionals aren't familiar with, and I think it's worth discussing those today because they are relevant for patients with neuroendocrine tumours. Now, diabetes mellitus is common, and it's the 6th leading cause of death in the UK, and there are up to 1 million patients that have undiagnosed type 2 diabetes. And we know from epidemiological studies that I mentioned earlier that cancers such as liver and other gastroenteropancreatic tumours, kidney tumours, breast tumours do confer an increased risk to diabetes. Let's move to now how we diagnose diabetes. And we do this taking a history, reviewing symptoms, and there'll often be an increase in thirst, what we call polydipsia, but also an increase in passing urine, polyuria. We need to have bloods to confirm that this is diabetes, and we can have random blood glucose levels or fasting blood glucose levels, and you'll see here I've put on the ranges. If there are no symptoms, we do not base the diagnosis on a single test. Now, some of you may have heard of the glycosylated hemoglobin, the HbA1c, and this is the blood test that looks at the glucose that's bound to the red blood cells, and the lifespan of a red blood cell is about 3 months. So this test generally looks at what's been going on over 12 weeks. And the diagnostic level is 48 millimoles per mole, or 6.5%. And this gets repeated if there are no symptoms. We are cautious with the HbA1c because of the reasons that I've stated. So if there's an abnormality such as specific hematological problems, we don't use HbA1c and we'll use glucose levels. We're very cautious in pregnancy, and if there's been an acute illness, and also for the diagnosis of type 1 diabetes and in children and young adults. Clearly, if there's been pancreatic damage or there's been surgery or a patient's acutely ill, we're very cautious with the use of HbA1c. Why is this important for patients with NETs? Why bother about a talk on diabetes? Well, let's move on with the classification. And we mentioned already type 1 and type 2 diabetes, but if we really want to follow classifications correctly, there is also a type 3 diabetes, which then itself is subclassified A to E. I'm not going to talk about the genetic defects that affect type A or B, but I would like to go on and talk in a bit more detail about type 3C, D and E diabetes mellitus. And it may be that some of you are familiar with this because you've seen this before, but it is not really very well known. So looking first at type 3C diabetes, so this is where anything can happen to the pancreas. So if there's pancreatitis or surgery or damage to the pancreas or pancreatic neuroendocrine tumour, this may affect your blood sugar control. And you might have symptoms of weight loss, pain, tiredness, diarrhea, steatorrhea, and blood sugars may go up or down depending on the scenario. Moving then to type 3D diabetes, this can be the result of hormones that might be secreted by the neuroendocrine tumour. And then finally, type 3E diabetes is a result of drugs that may be given to treat the tumour or to treat issues with the tumour. So this is a picture of the pancreas, which sits in the abdomen. And if we look more closely at this and take first the type 3C, you can see here that if there is damage to a pancreas, this can cause hyperglycemia or type 3 diabetes. And here on this side, we can see where hormones are produced. And the examples given here are those rare pancreatic neuroendocrine tumours secreting glucagon or somatostatin. Even more rare tumours such as Cushing's or acromegaly can also cause diabetes. And here, treatment of the tumour, removing it or directly treating those tumours can improve the situation and in many cases the diabetes, the type 3D diabetes. Finally, drug-induced diabetes or type 3E diabetes mellitus can be commonly from steroids or glucocorticoids, but also here mTOR inhibitors, checkpoint inhibitors, and medications that we sometimes give for insulinomas, diazoxide, to push up blood sugars can also actually induce diabetes. And it may be here that the somatostatin analogues can sit as well. So let's look at treatment now of diabetes if you do have a neuroendocrine tumour. And I've taken this from a recent publication. You can see that they've nicely divided up the types of diabetes into 3C, 3D and 3E in these columns. And I'll point out, as we mentioned before, if you have a tumour that's secreting a diabetogenic hormone, the best thing, if possible, is to remove that. Otherwise, I'll point out that metformin, which is an oral agent, is extremely useful in the treatment of all of these conditions. And metformin's been around a long time and is a really good drug for insulin sensitizing. And I've picked out a paper on metformin to discuss further in the talk. You'll also see further down this table that insulin features, and frequently when there has been damage to the pancreas, insulin is often required. And this type of diabetes is very challenging to manage in some scenarios. You'll see further down that there are other medications, some of the new medications can be used, but often the ones in the red block need to be managed with caution. Moving on to what data is available with diabetes and neuroendocrine tumours specifically. So publications have gone up year on year, and I did a quick PubMed search, and there were over 1,000 hits when you put in the search engine diabetes mellitus and neuroendocrine tumours. And I thought over the last sort of 10 years there were 18 or so publications that were relevant, and I've picked out a couple of them to discuss with you today. So this is a publication from a couple of years ago from a group in New York, and they looked specifically at gastroenteropancreatic neuroendocrine tumours and diabetes mellitus and survival. They have access to a database called the SEER database, and this is essentially a surveillance and epidemiology registry that's linked to Medicare, which is healthcare in North America. And interestingly, what they found was that having diabetes and a GEP-NET did not affect your overall survival, but they did find that the prevalence was high and associated with race. So if you were of a Black or ethnic minority group or had other comorbidities. In addition, they found that pre-existing diabetes didn't affect the overall survival as mentioned, or the disease-specific survival. So let's go back to our picture of the pancreas and now talk more specifically about each type of diabetes. And this is now looking specifically at pancreatic neuroendocrine tumours. So let's look at type 3C diabetes mellitus, and this is where there's damage to the pancreas. And this paper found that the incidence of diabetes was related to the type of surgery that you had, and if you'd had a distal pancreatectomy, the incidence was 21% compared to 16% if you'd had a pancreatoduodenectomy, and if you had a central surgery, that was measured at 6%. Interestingly, there was one study mentioned in this analysis that looked at the median time to development of diabetes if you'd had pancreatic surgery, and that was around 16 months. And of course, pancreatic surgery not only has implications to the development of diabetes mellitus, but also other exocrine function. And so this is the interplay of nutritional digestion and absorption and the need for additional pancreatic enzyme supplementation. This paper made a few recommendations about management, and this included avoiding skipping meals and having small frequent meals, and looking carefully at the type of carbohydrate that's being ingested and recommending complex carbohydrate and avoiding sort of simple sugars. And again, they recommended here treatments such as metformin and insulin, like we reviewed before. Is diabetes a risk factor for the development of pancreatic neuroendocrine tumour? So this question was reviewed in this paper, a meta-analysis looking at impact of diabetes mellitus in pancreatic NET. And what they found was that pre-existing diabetes mellitus is a strong risk factor with an odds ratio of 2.7. And when this was adjusted for body mass index, it was still over 1. So it's not clear if this is because there is a paraneoplastic phenomenon early on before the development of the tumour, or whether it's tumour-induced impairment. But the prevalence was quoted to be between 16 to 20% and higher in patients over 60. So we've got this closely linked so-called bidirectional relationship, but does diabetes cause pancreatic NET, or is pancreatic NET the cause of diabetes? And it's also a risk factor for gastric neuroendocrine tumour. Something the paper also highlighted was that diabetes mellitus is underdiagnosed in pancreatic NET and also not classified as type 3 diabetes. And I think this is a fairly common finding. And when I share our local audit data, we can make some suggestions to try and improve this. So moving on to type 3D diabetes mellitus. And so this is those types of diabetes that occur because of hormonal secretion. And a typical syndrome that we can mention is glucagonomas. Now these are rare. This may present with a necrolytic migratory erythematous rash, painful tongue, glossitis and cheilitis, angular cheilitis, and a normochromic normocytic anemia. DVT can also be a feature, and it may be that this might be part of a syndrome. The diabetes mellitus here may be mild, but clearly treating the glucagonoma is paramount to treating the underlying diabetes as well. I mentioned also stomatostatinoma to this audience because this presents with steatorrhea and can also have diabetes gallstones and be part of a syndrome. There are other ectopic hormones that I mentioned earlier as well that can cause diabetes, and ectopic ACTH going on to cause glucocorticoid excess in Cushing's is also one of them. The very rare vasointestinal peptide secreting tumours are also diabetogenic. And clearly treating these underlying hormonal excesses is one way to manage the diabetes. Type 3E diabetes mellitus is that type that's induced by the medications that may be given, and this includes the somatostatin analogues, which act predominantly on somatostatin receptor 2. And this inhibits the endocrine secretion of the pancreas, and in the Clarinet study, up to 5% of patients were found to be hyperglycemic. And you may have heard of another somatostatin analogue called pasireotide, and actually nearly 30% of patients developed hyperglycemia on this treatment, shown here in the picture. And this is because pasireotide acts on multiple somatostatin receptors. Moving now to targeted therapies such as everolimus, this is given in advanced pancreatic NET. And this was found in the RADIANT-3 study to have a 5-fold increase in the diagnosis of new diabetes, but also the diabetic emergency diabetic ketoacidosis was reported. Interferon alpha can also cause type 1 diabetes through immune activation, but we don't use as much interferon in this country as is used in Europe. And then finally, cytotoxic chemotherapies, they can cause beta cell death and thus cause diabetes mellitus through cell destruction. And again, management of diabetes does need to be personalised, and you'll recall the table we went through earlier with all the options. And I mention here simply newer drugs that are out there that can also be used for diabetes that work on other systems. Specifically now, what about somatostatin analogues and diabetes mellitus? So here I've got a couple of papers that I just want to run through briefly, and this was a paper published last year from the team in Birmingham, and they did a retrospective review of their neuroendocrine tumour patients on somatostatin analogues, and they found that despite a decrease in the body mass index, the HbA1c went up, and in over 200 patients they reported nearly 20 new cases of diabetes mellitus. And in pre-existing patients who had pre-existing diabetes and were commenced on analogues, there was a decline noted in the HbA1c in up to 5 of those patients. Now clearly that's a real-world review, an audit of practice, but a bigger review was also carried out by that same group in New York who published that previous paper. And here they looked at the association of somatostatin analogues and diabetes, and using the SIA database, they found that they didn't feel that somatostatin analogues in this cohort caused a statistically significant development of diabetes, but that the risk factors they found were, again, ethnicity, pancreatic surgery, tumour size and site, having a pancreatic lesion, but there was a high incidence in the cohort of over 53% of having diabetes anyway. There is a comment in this paper that the patients that were in this study, perhaps not as many were treated with somatostatin analogues than are generally in real world data. What about metformin? So going back to metformin, which is a drug that I mentioned earlier, there have been some signals about metformin being a interesting drug, and there was a post hoc analysis of the Clarinet study, which I'll remind you was a phase 3 international randomized controlled trial where patients were given lanreotide autogel, and then progression-free survival was the endpoint. However, they did a post hoc analysis to look at diabetes and diabetic status, and what they found that pre-existing diabetes wasn't a negative prognostic factor, and that in fact patients with diabetes mellitus and treated with lanreotide had even greater benefit. What they did notice in the placebo arm was that those patients with diabetes had a tendency to lower progression-free survival than those without, and potentially they felt that there might be an impact of metformin in pre-existing diabetes in the placebo arm. So a further study was then carried out called the MET-NET study, and this was a phase 2 trial of treating patients with metformin to use metformin as an anti-tumour drug. And they gave this twice a day to patients with well-differentiated neuroendocrine tumours up to progression of disease. And actually, it didn't have great activity as a monotherapy. And in previous studies, it had been shown that metformin alongside other treatments had been had more of a signal as an anti-tumour drug. So although this wasn't a positive study, I think it's important to be aware of it, and that metformin itself as a drug is extremely useful. So what are our goals when we're treating diabetes mellitus in neuroendocrine tumours? We want to look at personalised glycemic targets, and we can look at the targets set by the American Diabetes Association and the European Association. But also the therapeutic approach needs to be reviewed, because if there's an underlying cause that can be treated and the diabetes can be put into remission, this is certainly something to be considered. And I'm thinking particularly of neuroendocrine tumours that can be resected, such as glucagonomas. So just now, coming towards the end, I'd like to share with you some audit data that's unpublished from Sheffield, which highlights some of the things that we've discussed today. And one of our clinical fellows found that at presentation, patients with pancreatic NETs, only about half of them had had documentation of an HbA1c, so essentially a diagnostic blood test for diabetes. And this concurs with that SEER database publication. We also found that only 40% of patients were getting annual HbA1cs, and that up to 20% of patients with pre-existing diabetes had pancreatic NET. We also noted that 21% developed diabetes after their diagnosis of PNET, and that up to 12% needed treatment with insulin. So this all fits in with published data, but the reason it was important for our centre was that we felt that we could maybe put this all in a data set so that the HbA1c could be requested by those physicians who may not be as familiar with managing diabetes in neuroendocrine tumours, and hence improve the investigations for diabetes in these pancreatic NET patients. So what we've seen is that diabetes is a risk factor for neuroendocrine tumour, and there may be this bidirectional relationship that pancreatic neuroendocrine tumour may be a risk factor for diabetes. Age, surgery and position of the pancreatic NET is significant, but that we haven't seen that diabetes has an effect on overall survival or prognosis, which is good. We've noted that metformin does have some antiproliferative properties, but as a monotherapy perhaps is not as effective, and it may be further studies are needed. So finally, in conclusion, I hope this has given you some background to diabetes mellitus in neuroendocrine tumours, and that we've looked at the post hoc analysis of metformin in the Clarinet study and the METNET study, and that perhaps we've got some suggestions of how we can improve our follow-up of patients that may have diabetes or at risk of development of diabetes in the neuroendocrine clinic. Now, clearly more studies are needed, and we do need to increase awareness and improve our local practices. So thank you for your attention, and I'm happy to take any questions in the Q&A.